Hi, good evening, everybody, and extend a warm welcome to all of you to this, the inaugural session of our group, which we call DADI, Dermpath Academy, the Dermpath Academy and Diagnostics of India Limited. And uh, this is a group which actually originated in our last year's Dermpath Society meeting in Visakhapatnam. And during the discussions there, it had emerged that there is one great point which is missing in our national pathology scenario, which is the issue of distance or digital diagnosis. Because as you all know, the Medical Council of India, which is the NMC now, they do not recognize this. And this is a facility which is available all over the world. In our country, at the moment, it is not. Some of us have been, talking about it and asking that this should be, permitted, given a certain amount of critical things like, good scanner, good diagnosis, recognized pathologists, and so on and so forth. We'll see how that happens. And the other issue which was raised during those meetings in Visakhapatnam was the lack of, organized teaching in dermatopathology. A lot of people, as you know, a lot of countries, they have, fellowship in dermatopathology, they have, certifications, residencies in dermatopathology, and so on. We in India, as yet, do not. So that was also one issue which we feel needs addressing. So these were the two major objectives with which we started this group. And as you must have seen in the website, there are three of us at the moment. Two are all of us are dermatopathologists, and two of us are actually recognized dermatologists. And we, as I said, we have a 2-point agenda. One is academics of all sorts. The other is diagnostics using the virtual platform. So I would now request Dr. Nandakumar from Trivandrum to tell us briefly about the academic scope which this program hopefully will be addressing.
Hello, everyone. Thank you for this overwhelming response to our first meeting. We hope to provide structured academic programs in our meetings, starting with the CPC this time. This will be conducted in such a way that the participants would be exposed to the nuances of dermatopathology right from the basics to the higher level in a very structured way. We will be having regular lectures plus CPCs, real world slide discussion, so on and so forth. We have a lot of plans to take it to the next level, including in future instituting a fellowship in dermatopathology. So once again, welcome everyone to this program and participate in a big way. And if there are any queries or doubts that you need to be addressed, you can put it that in the chat box. We will try to clear it for you. Over to Dr. Sasi, Attili. Sasi, you are muted.
Okay. So yes, hello everybody. Welcome to this meeting. So I'm just going to share my screen so that I can discuss what we are up to. So I hope you can see the screen here. So this is the website. I hope all of you have gone through it. So our aim, as already discussed by Manoj Singh sir and Nandakumar sir, is twofold. One is to have an online reporting wing, because we have a slide scanner. So this allows everybody, anybody, anywhere in the world to send us a sample, a block, whatever, and we'll be able to scan it. And the reporting pathologist does not need to be anywhere near the lab. They can be anywhere in the world. So eventually, hopefully in future, you're going to have international experts in the panel, and say you don't like my report or Nandakumar sir's report or Manoj Singh sir's report, you can always ask for a second opinion from, say, Eduardo Colonge in the UK, or you can ask for, Dr. Ram or whoever is in our panel, in future. So that's the plan. That's the part of that's the beauty of having a digital dermatopathology reporting wing. But all the cases that we're going to report will be scanned, and it will be an immense learning asset. And the plan is that all these cases will then move on to the learning hub. And the learning hub, I mean, the website is still, so we've got diagnostics and we've got the learning hub. The learning hub essentially involves a number of things. We'll be having video libraries, lecture modules. We'll be having cases that you can go through, quizzes and assessments. Now, this CPC program is also part of the learning module. This CPC program will be free. It will be once a month, every Wednesday, every last Wednesday of the month. You attend the first one, obviously, and we'll have a few prizes just to entice you. But most importantly, we are really excited about the fellowship. And the fellowship that we planned is going to be a flexible one. Right now, the slots, the website is still not taking bookings right now, but we are going to offer 50% off for the first 10 enrollments, and we're going to have a 3-month, 6-month, 12-month, and 24-month plans with 50% reduction for the first 10 subscriptions. But the beauty of this is, if you are taking the 24 months plan, for example, that's a 24 months fellowship, right? You'll have access to a full slide collection, monthly CPCs, lectures, mentorship sessions, research, certificate with a pass distinction. There'll be an exam, the exit exam. And the beauty of it is, once you've gone through all the slides, you'll be, certified, and you'll be prepared for the IJDPDD exam in Frankfurt, which is a European diploma exam. They have a mandatory number of slides that you should have seen. And this website allows that, because so far in India, there is no such certified training center. Each individual training center has to apply for it and say that, we have trained this fellow and he's seen X number of slides. Can you please allow him to take the exam? And a few people have taken the exams like that. But then because this fellowship automatically allows that, we are going to, make sure that you'll be fully prepared to take the European diploma exam, which is currently the only easily accessible exam for Indians. We don't have an Indian dermatopathology exam, which hopefully DADI will be part of in the near future. So with the guidance of seniors like Manoj Singh sir and Nandakumar sir, I hope that this will really take off. So that's my 2 bits. I'm going to hand over to our sponsors today, which is Glowderma. They have a small corporate presentation for about 2 minutes, and then we'll kick off the session. Thank you.
Thank you so much, sir. Before starting our presentation, I would like to thank you to Dr. Sasi sir, Dr. Nandakumar sir, and Dr. Manoj sir to giving an opportunity to present here. And thank you again for the trusting on us. So welcome you all for the DADI presentation and an educational support by Glowderma. So I would like to present Glowderma. So Glowderma have a core purpose, that is elevating lives, and core value, that is meaningful innovation, unwavering commitment to the quality and safety, continuous improvement, and result through teamwork. And we have aspiration core value, that is customer success above all else. So Glowderma have a 7+ first time Indian brand launch, and 400 plus enterprising Glodermans, and 113th rank in pharma company in India. Gloderma have a 700 plus distribution channels and 9,000 plus associated dermatologists and skilled R&D team who develop innovative products. Also, Gloderma have a product mix like antifungals, moisturizers, acne care, and hair care. Also, we have a psoriasis care, topical steroid, vitiligo care, and nutraceuticals. So, Gloderma is India's first company to make all products are paraben-free, sulfate-free, and detergent-free. So, Gloderma have a patient safety is of a paramount concern. So now I would like to introduce about flagship brand, that is Moist, the most advanced moisturizer and cleanser. In Moist, we have a Moist cleansing lotion, Moist cream, Moist Moist LMF48, Moist XL, and Moist Scented Bath. Along with that, we have a most advanced ketoconazole range, that is Kion, the advantage of solubilized ketoconazole in lipid phase. In Kion, we have a Kion Stay On lotion, Kion soap, Kion zip, Kion tablet, and Kion cream. Also, we have a hair care range, that is alcohol-free minoxidil solution, the Minoboost and Minoboost F, the topical hair solution, formulated in lipid base and enriched with procapil. In Minoboost, 360-degree spray applicator and dropper. Also, Gloderma is India's first company to introduce ozonoxacin molecule in novel non-fluorinated topical quinoline. So, Ozodex containing we have a Ozodex cream and Ozodex lotion. Also, we have a tie-up with the Sanosun Baby, that is made in Germany company, the premium pediatric section. So, Gloderma have a tie-up with Man & Shoulder company, international collaboration. So, bring world-class derma tested certified with a natural and safe baby skincare product in Indian mothers. So, Sanosun Baby is made up with one global, one formulation, 40 plus years of expertise in baby skincare and present 17 plus countries. Also, Sanosun Baby gained the trust and confidence of 250,000 of Indian mothers. So, Sanosun Baby, more than 90% natural ingredients, 0% SLS and SLS free, and clinically tested hypoallergic. So, Sanosun Baby with a milk, protein, and organic olive oil. So, that's all about Gloderma. Thank you so much. Thank you, all of you. I will go over to Dr. Manoj, sir.
Thank you. I'll just moderate the session for the first. Dr. Manoj Singh, sir, will go ahead with his 3 cases, which I'll put up in a second, and then followed by Dr. Nandakumar sir's cases, and then that will be followed by my cases. So, Manoj Singh, sir, so this is your first case number 1. All yours. You please tell me what you want to show, and I'll zoom in and zoom out.
Okay, so as you can see, we have here essentially almost normal epidermis and keratin, but there are these large areas in the dermis extending up to the mid dermis and maybe even the lower dermis, almost reaching up to the paniculars, where there is, there are these dense infiltrates. Can we go on higher on these? Any one of these? Lovely. Lovely. Now, as you can see, this essentially is a collection of these histiocytes and some inflammatory cells. Now, these histiocytes also, as you can make out, can we go higher, Sasi? You can make out here, these histiocytes contain something, Ida, right? And you can make out that each one of these histiocytes has got anything from, like 8 or 9 to 15, 16 of these organisms. And the other thing which you might like to remark here, which I will discuss a little later, is that the majority of these kidas are actually present inside the cells. Few of them are present outside, which means majority of them have been phagocytosed. As high as we can go, Sasi?
I think it'll
that's fine. We don't want it to pixelate. Yeah. So we are here faced with a diagnosis of a very large amount of organisms present in the dermis, in the inflammatory infiltrate. Most of them have actually been taken up by histiocytes. And there is this scattered, scant kind of inflammation surrounding it. Can we now go to the slide, Sasi? Just see, just a little bit, let's see the dermoepidermal area. Just zoom in here. Yeah. You can very nicely make out that one thing, that this inflammation is extending up to the epidermis, but the Grenz zone is not involved. So whatever these are, perivascular infiltrates of varying sizes, which consist mainly of these histiocytes and lymphocytes. Go on to the next the PowerPoint, please.
Yes.
So given this, the diagnosis which we would consider is, of course, as you all know, we talk of crypto, we talk of histo, we talk of leishmaniasis and whatever it is. So can we see the PowerPoint? So this necessitates that we should do some special stains in this. And what are the special stains which we do in this? Depending on what.
Can you see the PowerPoint here?
Yeah, please.
Yes.
We don't go back to the scan. We just finish with the PowerPoint.
You want me to move on to the next slide?
The PowerPoint, please. Somebody has written pass and.
Is that PowerPoint being shared?
Yes, please.
Okay, just a second. I think the PowerPoint is not being shared, right? Okay.
Yeah, now it has come.
It has come
Right.
now. Yes.
Okay, fine. Okay.
So, as you see with the label, you can make out here, this is a case of cryptococcosis, and this is the HLD. You can make out that a lot of the organisms are present in the histiocytes, in the vacuoles, and also a significant number are present outside. Can you see that? Next, please. Again, HLD, showing that this organism is present here and here. And on the HLD also, you can make out that each one of these organisms, whatever it is actually surrounded by this clear space. I mean, whatever it is, because it's already labeled cryptococcus, isn't it? And you can just back one slide, please. This is the Alcyon blue pass, and Alcyon blue, as you know, stains the mucoid material. And you can here make out that in cryptococcosis, this material, the capsule of the cryptococcus is actually staining positive. And here in this one, you can make out very nicely that the capsule is positive, and inside there is a small PS positive organism, like here. Next, please. One issue which was brought to our notice by our very, very dear colleague, Dr. Navjeevan Singh from UCMS, is that many of these organisms, they actually polarize. So for many of these organisms, they polarize, and if the load is less, polarizing might be a good way of, I mean, not in the kind of case which I am showing, but when the load, organism load is less, polarizing may be a good way of identifying that something unusual is here. Next, please. And then similarly, histoplasmosis, as I had mentioned. Now here you see some organisms which are present, but here you will also make out that these organisms are mainly present inside the vacuoles. Not so many are present in lying free. There is a reason for that. Next, please. This is the silvermethenamine, showing you that the organisms are actually staining positive for silvermethenamine, as you can see here. And actually, I don't have a photo of that here, but the Alcyon blue pass shows that that capsule is missing. The capsule of crypto is missing. And you can actually make out that a little bit on the HND and the silvermethenamine also, that the space which the capsule should have taken is not free, these organisms are virtually touching each other. So that indicates that capsule here is missing. Next, please. Okay.
This is the AIDPath.
Bad stain, but anyway, here you can make out that the pass is positive. Many of the organisms are in fact touching each other. Next.
I think that is it, sir.
Okay, fine. So one thing which we need to distinguish, and the reason I was saying, I was pointing out these things actually is the size of these organisms, because Cryptococcus usually present in the tissues is 5 to 10 microns in size, including the capsule, and histoplasmosis is 3 to 5 microns. In other words, histoplasma is smaller, which is why many of them tend to be eaten up by the histiocytes, and crypto, for that reason perhaps, is also seen lying free, because there's just so much space that the histiocytes have. So they eat up some of them, and some of them lie loose. So crypto, you would see present loose as well as inside the histiocytes. Histo usually is present inside. And of course, the great difference of the capsule, that you do mucicarmine, you do alcyl blue, you will see the capsule in cryptococcosis. And in this case, you had just shown that case, Sasi.
Which one, sir?
The scan. Can you? That's
You
okay.
want me to go back to
No, forget it. This case, actually, we are seeing exactly this issue, that most of the organisms are actually present inside the histiocytes. Let's go a little higher. Yeah, and that characteristic, pushing aside of the organisms because of the capsule is not there. So this case is something which we had diagnosed as a histoplasmosis. Can we go to the diagnoses?
So, yeah, but the history, sir, this one was that of a HIV patient who had multiple papillary nodules for 1 week. And given that we haven't given the pass or silver stain or whatever, so these are the answers that you discussed. You might want to elaborate.
So 34 people, 77 total number of submissions. 34 people called it histo, 25 or 26 called it crypto, and then a variety of other organisms, molluscum, and 6 people again crypto. And some people had called it, and so on and so forth. So we would, give marks to both histo and crypto. But I have tried to highlight how you can distinguish the two on the HND and especially on the special states. Next, please.
Okay, so I'll just quickly make a mention, sir, to everybody who doesn't know how we are marking it. So we had a discussion, the quiz ended at around 12 o'clock. So all 3 of us had a small meeting at 1:30 to decide how many marks to give each answer. So basically the way it works is the correct answer receives 1 mark, and if it's partially correct, we've given it half a mark. So in this particular quiz, none of the answers received half a mark. You either got 0 or 1. We had a discussion of leishmaniasis, but we decided that the organisms were pretty typical, and either it's crypto or histo, and you could not really make a diagnosis of leishmaniasis on this one. Okay. So going up to the next case, which is case number 3, sir. This is your case. Low power. And I'll go on to the epidermis first. Sir, all yours.
Yeah. Okay. So what you see here, obviously, as a lot of you have actually diagnosed this is a cancer, right? Many of you have actually called it that. This is a tumor which is infiltrating the entire dermis, right from the uppermost part down to the inside up to the fat also. And what is this tumor? Looks epithelial. So it's a epithelial tumor. Shashi, can we go to the epidermis area? Yeah, yeah. And then if you see the morphology, there is considerable anisonucleosis, some mitoses are there. So this actually is a malignant epithelial tumor. And there is no squamous differentiation, as you can make out here. So likelihood that this is a adenocarcinoma. And of course, the history given by Dr. Sasi is very, very suggestive, lesions around the chest. So adenocarcinoma in a lady and in the chest. So strong possibility that this is a breast cancer. Very nice. Now, Shashi, can we track the epidermis on higher power? You can make out that there is this, area of necrosis and crusting forming on the outside. And here, in the epidermis, here, you see these malignant cells, which are actually going into the epidermis. Yeah? Just track the epidermis, please, Shashi. Let's just see it on this power only. And you can make out nests of these cells present in the epidermis. You can make out single cells going into the epidermis. And actually, this is a little bit of a trick question, which, I gave in just to puzzle you. And I'm happy to report that some of you did get puzzled. Because the issue for the dermatopathology point of view was actually not the tumor itself, epithelial tumor looking malignant in the chest area, highly possible that this is a breast cancer. The important thing was the Paget's disease here in the epidermis. And the issue again for Paget's disease is the fact that usually we all see Paget's disease as, something, it's a standalone, something happening in the epidermis, some crust or some weeping lesion, and we look at it and we see malignant cell, we say, aha, there is a cancer somewhere, right? Here, this cancer was so very obvious that it tended to actually, blind out or obfuscate the epidermal change. And it is for this reason that I had tried to, kind of confuse you. So can we see the diagnoses, Shashi, please? Yeah. Yeah. So cutaneous metastasis, 18 people. Metastatic breast carcinoma, 18 people. Metastatic lobular carcinoma. Well, morphologically, actually, to me, it looks quite like a ductal, not like a lobular. But the consensus was to give some marks for these people also. And then, of course, non-Hodgkin's and sarcoidosis and mycosis and so on and so forth. We did not get any marks at all. But the issue is that, somebody called it a colorectal going to the breast, which is very unusual, but I have seen a couple of cases, colorectal, rectal carcinoma, adenocarcinoma going to the breast. So we gave some marks for this. But the other issue, of course, as I succeeded in foxing you, was the fact that the epidermal changes also need to be seen. And this kind of appearance, it's you see it when you see a cancer of the breast and it's extending up to the skin. Many times you do see Paget's, but this particular thing is something which gets ignored. So I had actually given this case for that reason. And nobody called it a Paget's, right? Sasi?
Nobody called it Paget's, but somebody called it inside to ductal carcinoma, which it isn't.
Well, it is.
There is mammary pages disease. One of them is called it mammary pages disease.
Mammary pages, yeah. Oh, okay. I'm sorry. This person should have been given one. Yeah, this person should have been given one.
You want one mark given for this?
Yeah, one. This case, this person only. Because, adenocarcinoma or cancer of the breast or a breast carcinoma, it is. That's something which is very obvious. But that particular thing also needs to be noticed and remarked. So, usually when we diagnose patients, we see a standalone lesion in the epidermis, and then we start looking for a cancer somewhere. Here, the cancer was very much there. And it is for that reason that the patients got ignored. So,
I'm sure you want to give that 1 or 0.5 because you've given metastatic lobuli 0.5. And
the person has called it a Paget's. So that means that person has noticed Paget's.
Okay.
That person has noticed Paget's, which is what we were looking for in this case.
Okay.
So next case, please.
Yes. So move on to, I think, case number 9 is the next one of yours.
Case number 9 is the next. Yeah.
Yes. So I'll just concentrate on the middle one because that is
lovely.
Diagnosed.
Highly characteristic appearance. You can make out that there is this lesion extending from the epidermis down into the dermis. You can make out this kind of a cutoff, which is described in a seborrheic keratosis that it's there is a straight line of division between the uninvolved area and the involved area. And in the involved area, can we go higher, please? There are these strands of cells, epithelial cells, which are enclosing these varying size, one would call it papillary structures, but these are much more than that. These are much more extending into the dermis. So there is, this lesion has an epithelial component and a mesenchymal component. And this, as many of you have actually rightly diagnosed this is a fibroepithelioma of Pincus. Pincus Sahab described this, and there has been a controversy. You can make out in some of these strands that there is this, palisading appearance, which you see in a basal cell differentiation, but very, very scant mitosis, very small amount of anisonucleosis, and on the morphology, you'd find it difficult to say whether this is a basal cell carcinoma with this appearance, or a seborrheic keratosis with this appearance, or just this. So, can you please see the ranking, please? The diagnoses, and sure enough, 27 people called it fibroepithelioma of Pincus. Now, we have deliberately not given any marks to basal cell carcinoma, seborrheic keratosis, intradermal nevus, because this remains a diagnosis of confusion. Whether it is actually a basal cell carcinoma, or it is actually a seborrheic keratosis, or it is both, is something which, it's abstruse. So, usually, it is described as a low-risk, non-aggressive, non-metastatic tumor. Some people have related it with the trichoblastoma, but what exactly it is very unknown. And an excision, an adequate excision, as we have in this case, usually suffices to remove it. And it has never recurred. It does not grow back. So, as I said, low risk. So its exact position between the carcinoma and non-carcinoma group is confusing. But the issue is that appearance, which you saw on the low power, which Dr. Sasi was saying, is so characteristic that, this is something which must be noted remarked, and you jump up and down in your chair when you see this. So, Dr. Aarti Bakshi from the UK has remarked in the comments that the WHO has actually called this. WHO has called this. WHO has called this a variant of basal cell carcinoma, as it may be, but morphologically it is still defined as a the descriptions: low risk, non-aggressive, non-metastatic. If it is at all a basal cell carcinoma, then it's a very, very well-behaved basal cell carcinoma. So you can go with that, and let us see if other people have seen more cases. We can perhaps put our cases together. That is one part of the function of our group, DADI, that if somebody has these unusual cases, we put them together. So let's see. So thank you all very much. I now hand over to Dr. Nandakumar, who will be discussing his 3 cases.
So this is the first slide of case number 4, which I'll just give the brief history, sir, because I think
please.
Not giving that some people may be joining only, they may not have seen the quiz. So I'll just give the brief history here. So the history we're given for this case is a 34-year-old woman who presents with a solitary tender subcutaneous nodule on the lateral thigh, present for 3 months with minimal change in size. She denies symptoms of fever, weight loss, and night sweats, but has had a history of photosensitivity in the past. So that is the clue to the diagnosis to some extent. So all yours, sir.
So we have actually provided 2 sections. One with the epidermis and the dermis, and the other mostly contains the subcutaneous tissue. When you have such a kind of section, it is imperative that you first look at the one with the epidermis and then go down to the dermis and then to the subcutaneous tissue. Then only we will be able to arrive at a proper diagnosis. So here actually it shows a mildly atrophic epidermis, and if we look carefully, we can make out that there is very focal interface change with upper dermal mononuclear cell infiltrate. The infiltrate also localizes around dilated capillaries of the upper dermis. As we go down to the mid and reticular dermis, we can appreciate that there is a significant periadnexal infiltrate of similar cells also, mononuclear cells located around the eccrine and pocrine structures as well as around the hair follicles. There are sparse interstitial infiltrate also. No appreciable extraneous material is seen in this section. So to summarize, we are seeing a slide with minimal interface change, perivascular and periadnexal infiltrate. Can we go to the subcutaneous tissue? Yeah. So the main pathology resides in the subcutaneous tissue, and the scanner view itself shows that the infiltrate basically involves the lobules with spillover into the septate. Can we just zoom in a little bit? So it is primarily a lobular infiltrate. And whenever we see a lobular infiltrate, we tend to call it as a lobular paniculitis. Before we use the term paniculitis, it is very important to go to the high power view and look at the morphology of the infiltrating cells. So here we are seeing majority of the cells to be mature appearing lymphocytes, and there are a sprinkling of plasma cells also among the infiltrate. So it is a lymphoplasmacytic infiltrate involving the lobules primarily. There are, can we see the septae with the thick-walled blood vessels? Some of the septae show this kind of a thick-walled blood vessels are seen. Can we zoom in a bit? And it shows infiltrate of these cells into the wall of the blood vessels. So there is an element of vascular component also. There is no appreciable necrosis, no significant cellular atypia, no granuloma formation. I am just mentioning the relevant negative points also. No granuloma formation, no giant cells. So we have a lesion which shows interface change, periadneXal infiltrate as well as lobular infiltrate of mononuclear cells with a good number of plasma cells, few histiocytes containing karyorectic debris. No cellular atypia is appreciated. Histopathology wise, this fits in with the diagnosis of lupus paniculitis. Having said that, we should also consider the important differential diagnosis like subcutaneous paniculitis like T-cell lymphoma and erythema induratum, which is the commonest form of lobular paniculitis that we see in our day-to-day practice. I have already enumerated the relevant negative points by which those two diagnoses were excluded. The final diagnosis rests with the serological test reports also. And some of these cases may have to be kept under follow-up to rule out them developing into a CPTCL. So this is the response that we have seen. A majority have diagnosed it correctly as erythema, lupus erythematosus or lupus paniculitis. If you have made a diagnosis of subcutaneous paniculitis like T-cell lymphoma, we have given half mark to that. Atypical lymphocytic lobular paniculitis, when you are really not sure what we are dealing with, also gets half a mark. Lobular paniculitis, credit goes for recognizing it as a lobular infiltrate to differentiate it from septal infiltrate. And lastly, erythema induratum. Even though in this particular case, erythema induratum doesn't really come into the differential diagnosis. A patient was worked up with serological tests and his ANA profile was found to be, and her ANA profile was found to be positive. ISC is pending. That's all for this case. Can we go to the next slide? Sasi, could you please give the history?
Yes. So the history for this case is actually pretty typical. The history given was that of a 29-year-old man who presents with a solitary violaceous patch on the medial thigh that appeared abruptly 3 days ago. The lesion is mildly itchy but not painful. He reports having had a similar lesion in the exact location a few years ago. So that is the history.
Again, the scanner view is very revealing. Upper dermal pathology we can make out. The mid and lower dermis appears to be fairly spared. We can see that there is minimal hyperkeratosis. Keratotic plugging is there. An infiltrate which is lying very close to the basal cell layer with basal cell degeneration is seen. So definitely there is an interface reaction is there with very prominent pigment incontinence, and there is moderate amount of upper dermal lymphocytic infiltrate, with the infiltrate actually is seen extending into the lower portion of the epidermis also. That is also a significant point to be noted when you are trying to interpret this slide. There are few necrotic keratinocytes in the lower portion of the epidermis, and correlating with the history, the most probable diagnosis in this particular slide is that of a fixed drug eruption. The differential diagnosis, naturally, it has to be excluded from, it has to be differentiated from lichen planus. Lichen planus, why there is no cellular infiltrate into the epidermis in classical lichen planus. Why it is not erythema multiforme? In erythema multiforme, more of dermal edema will be seen, but it's in very early stage of erythema multiforme can look like a fixed drug eruption. So the differentiating points are little subtle and subjective to the clinical picture and available clinical data. So this was diagnosed as fixed drug eruption. And we have a huge number of people who got the slide right. Very happy to say that. Lichen planus pigmentosus, why it is not lichen planus, I mentioned. Bullous erythema multiforme, we are not seeing any bulla in the first place. In erythema multiforme, typically the necrotic keratinocytes extends throughout the thickness of the epidermis, which is not seen here. It is confined to the lower portion of the epidermis. Granulomatous, I think the rest of the diagnosis doesn't deserve any credit. You cannot make a diagnosis of lichen planus with this slide. That is the point which I want to highlight. Erythema multiforme versus fixed drug eruption, agreed. But you cannot make a diagnosis of lichen planus with this slide. Can we go to the next? This is my last case again. For those who are familiar with the lesions, a very straightforward histopathology.
Can I give the history, sir?
Yeah,
so,
please.
A 48-year-old woman who presents with multiple tense blisters over the extensor surfaces of the forearms and shins, developing over the past month. 48-year-old woman. Lesions are mildly itchy and heal with scarring and milia formation. So that's the clue here.
See, whenever you are reading a history, we should be aware that the history is significant, especially for an exam. When a history is given, it contains a clue. In this case, the history definitely contains two clues. One, with regards to the possible level of blister formation, and second, regarding the nature of the lesion. So give always importance to the history given. So here we are seeing a subepidermal blister, isn't it? Whenever we are faced with a blister in histopathology, the first attempt on our part would be to make out the level of blister formation. And how do we make out the level of blister formation? You look at the edge of the blister. The edge of the blister is the best place to look for the level of the blister. The roof, what forms the roof, what forms the floor. So here you can see that the basal cell layer forms the roof and the papillary dermis forms the floor. And there is a bit of regenerative changes are seen. So it is a clean subepidermal blister with very minimal fibrinous material, almost no cellular infiltrate seen within the blister cavity. The upper dermis shows dilated capillaries and a sprinkling of lymphocytes. No significant eosinophils are seen among the infiltrate. So one or two eosinophils are seen, but not too many. So it is a subepidermal blistering disease. Few of you have gone wrong with the level of the blister formation. You have offered a diagnosis of pemphigus, which it is not by any stretch of imagination. This is a subepidermal blister, cell-poor type of subepidermal blister, and with the history given. So this is a dermatopathology teaching session, isn't it? With the view, we have to incorporate the history into the final diagnosis. The history given, it is epidermolysis bullosa. Epidermolysis bullosa acquisita. Right. 41 have got it right. I'm not sure why 39 made a diagnosis of bullous pemphigoid. The most important differentiating point between the two is not, in favor of bullous pemphigoid is not seen in this slide. Bullous pemphigoid typically shows a rich infiltrate containing good number of eosinophils into the blister cavity as well as into the dermis, which is not seen. Agreed, we have to do a direct immunofluorescence, perhaps coupled with a salt split technique to identify the level, the region where the antibody is located. But Bullous pemphigoid as a primary diagnosis in this slide should not be offered. Porphyria cutanea tarda, this is not the histopathology of porphyria cutanea tarda. Is there any dermal festoons? Are there any vessels containing that hematoxyphilic material? No. It is not pemphigus vulgaris, obviously. Dermatitis herpetiformis, no. We are not seeing a multiloculated blister with the papillary microabscesses. Bullous systemic lupus erythematosus, where are the findings to make a diagnosis of lupus erythematosus in this slide? No. So it boils down to one histopathological diagnosis. I stress the point, histopathological diagnosis, that is epidermolysis bullosa acquisita. Familiarize yourself with this kind of a lesion because it's very common in our day-to-day practice, isn't it? I think that completes discussion of my slides. Over to Dr. Sasi.
Thank you, sir. So anybody who's got questions, please feel free to put them in the chat box. We are here to, this is an interactive session. So even though I'm presenting, if you still have questions for Dr. Manoj Singh, sir, Dr. Nandakumar, sir, we are happy to answer. So, I mean, I'm really proud of how the website has worked out there, though there's few technical glitches, which you would have experienced actually. But I hope you're happy with the way we've given you the option of adding a differential diagnosis thanks to Dr. Aarti Bakshi actually, who did the EQA session for us in Vizag when we had the DSI meeting. And I was pretty impressed by the way that the EQA session in the UK, they have an option wherein participants can put in a differential diagnosis, because dermatopathology is not 1 + 1 = 2. There are always differentials. And sometimes you're not sure of the diagnosis and you're allowed to have a differential diagnosis. And just because you don't know the exact diagnosis, you should not be penalized. So that way we have put in the marking here, wherein even if you get, if you give out of 100, if you give a weightage of 20 to say Cryptococcus and 20 to Histoplasma, and then the rest 60 you've given some other diagnosis, at least for this 20 and 20 you're going to get marks. So, so that's how we've intuitively designed the website. And a lot of hard work has gone into it. I hope you appreciate it, and future meetings will be even more crisper and less technical glitches, hopefully. So this is the case number 2, actually, which I gave a history of a 51-year-old male complaining of xerotic, ill-defined patches on the trunk and extremities, infiltrated plaques on the face, earlobes, arms for 2 months. Started on multi-drug therapy, obviously for leprosy, for 1 month, but slit skin smear performed 2 months ago was negative. But the patient now, after starting therapy, has developed fever and facial swelling. So, and this is a biopsy from that. So, if you see the low power, you can see that the epidermis is relatively intact, but you've got a superficial and deep infiltrate. And this infiltrate is periadnexal, perivascular, and majority of that is basically ill-defined granulomatous infiltrates with histiocytes and lymphocytes and giant cells. You can see numerous giant cells here. That's a giant cell. Lots of beautiful giant cells there. That's a giant cell. That's a giant cell. So this is obviously the history is pretty typical. I think anybody who knows even a little bit of dermatology would know that we're dealing with leprosy. The fact that split skin smear was negative does not exclude the diagnosis, especially when the clinical history and picture is pretty typical. And the tuberculosis spectrum, split skin smear can be negative. The second thing is the biopsy was obviously done because the patient was thought not to respond to treatment because he was developing fever and infiltration after starting therapy. But this is typical of this particular condition. Now, the infiltrate is composed of a few lymphocytes, not many neutrophils actually, but lots of histiocytes and neutrophils. It's diffuse, infiltrating in between the collagen bundles as well. You can see the infiltrate, the granulomatous infiltrating between the collagen bundles. And it's not the typical leprosy pattern where you see nice, well-defined granulomas extending along curvilinearly along the neurovascular bundles. It's not the typical pattern. But then it's not the lepromatous leprosy pattern either, where you see a diffuse infiltrate of foamy histiocytes. The histiocytes are not really foamy here. They've got nice eosinophilic cytoplasm. So they're not really foamy. So if you want to classify this, you would still put this in the tuberculoid spectrum. Okay. So, but it's not typical tuberculoid. So it has to be either, now it's shifting into either borderline tuberculoid or either borderline. But the history is a clue here again. As Dr. Nandakumar sir has been reiterating, the history is a clue. The patient started multi-drug therapy, and after starting it, he developed a reactional state. And this is leprosy in reaction. There is no vasculitis here, and there is no fat involvement, most importantly. And I think some of you have called this erythema nodosum leprosum. To call that, you need to have fat involvement. And the slide, at least the section that I've put up, not show any fat involvement. So let us go to the diagnoses that you've put in. So 30 of you have got it right. You've called it leprosy in reaction, for which you've given 1 point. We decided not to give any points for erythema nodosum leprosum. And because the history was so typical, we did not give any points to borderline tuberculoid leprosy either, because you need to make a diagnosis of leprosy in reaction. It's not enough to call this borderline tuberculoid leprosy, because a reaction state should not be missed. It should be called what it is. And that is the reason we decided not to give any marks, because the history was typical in this case for either borderline tuberculoid, borderline lepromatous, sarcoid, tuberculoid, leprosy be a borderline, and yeah, the rest of them are immaterial anyway. So there you go. So 77 people answered, 30 of you have got it right. I think there is a question in the chat box. Was the extent of infiltration, epidermis is not atrophic? Any comment of that for that? So epidermis, in my experience, yes, in the tuberculosis spectrum, you may often see epidermal involvement. Often there is a bit of vacuolar interface change. In this case, there's a bit of spongiosis. And in a reactionary state, that is expected. Why is there no interface change or epidermal involvement? Why is there maybe even I would call this a grand zone personally. So, I mean, the epidermis is involved with a bit of spongiosis, though the infiltrate doesn't extend up to the basement layer. But I don't think that's an excluding factor to either not call this a reactionary state, or to not call this the tuberculoid spectrum when you're mentioning the reactionary state. So, yeah, I hope that answers your question. The next case, moving on, is case number 7. Case number 7, again, is a very interesting case I saw recently. Low power, you've got 2 sections here. Low power shows 2 distinct diseases, and I hope you managed to pick it out. And you were supposed to give 50% weightage to both the diseases. The first one, very typical, wedge-shaped hypergranulosis with a bit of follicular plugging, a lichenoid infiltrate eating into the basement membrane with a max Joseph space. This is lichen planus, and I think you would be forgiven to also maybe thinking this may be follicular lichen planus, though you're not seeing the hair follicle here in the section. The history given here, by the way, is that of a 52-year-old man who presents with few hyperpigmented papules, not nodules, papules on the lower leg, some of which show a central crust. He reports mild pruritus and says the lesions developed over a few weeks after scratching. Okay, and so that's the history here. Typical histology here of lichen planus, but what's going on here? You can see here that the epidermis here is more or less eroded. You don't have the typical basophilic debris, but you can see here the clear transepidermal elimination of collagen and inflammatory infiltrates through the epidermis. So this is transepidermal elimination. I wouldn't really commit myself to calling this perforating collagenosis or anything like that. I mean, there is a bit of collagen here, but I don't believe that the term perforating collagenosis should be used. In fact, it's a reactive transepidermal elimination of degenerate collagen, if you want to call that that. There are a few neutrophils here. It's basically a reactive state. This patient doesn't have any systemic features of, doesn't have any renal failure, or neither is he diabetic, but it's basically a beautiful coincidence of lichen planus with reactive transepidermal elimination of the degenerate dermal material post lichen planus. And obviously the epidermis is eroded with the lichen planus. Whether it's follicular is up for debate. It may be follicular. And you can see the, pigment incontinence, the infiltrate, the lichenoid infiltrate basically being eliminated out transepidermally. You can see a bit of keratin and collagen here as well. So you were supposed to make two diagnoses. One is that of lichen planus and one is that of transepidermal elimination. So let's see what you've put up. So 30 of you have said acquired reactive perforating collagenesis. Now, because of the nature of this case, we have given 0.5 for both the correct diagnosis because the software currently is not geared up to give you to sort of diagnose, give you 1 point for both the answers. If we do, then even if you choose one of them, you're going to get full marks. So we decided not to do that. So therefore, because you were supposed to give 50% for each of the two diagnoses, we decided to only give 0.5 for each. So if you had reactive perforating collagenesis or dermatosis, it's 0.5. Lichen planus is 0.5. Transepidermal elimination is the same thing. The diagnostic database needs to be fine-tuned a little bit. There's still some diagnoses which are overlapping. So forgive me that I hope we can rectify that in the next few sessions. Perforating folliculitis and follicular lichen planus, we decided to give 0.5 again. So the remaining diagnoses get no marks. Okay. So there you go. So the next case and the last case is case number 8, which is this one. I'm going to show, actually not this, because I got to see this slide first. It's got two different sections, two different slides, in fact. The biopsy was taken from two different places. And the history in this case is that of a 24-year-old male complaining of itchy, raised red lesions over the body for 2 months. On examination, he had erythematous pruritic papules and small plaques with surrounding erythema scattered over the trunk, upper and lower extremities. So, in fact, the clinician gave me a differential diagnosis of pleva, with the second differential diagnosis being papillary urticaria, which I didn't put in here for a reason. But you can see here that the section here, I mean, you're supposed to ignore the bad section, look at the good section. And this is what practically happens as well. Sometimes technicians do a bad job. So these are real life cases. I want you to experience what we do as pathologists. Low part shows an intraepidermal pustule, a superficial and deep, mild to moderate perivascular, and a little bit of periadnexal infiltrate as well. You can see the infiltrate going around the eccrine glands for some reason, maybe the vasculature here in the deep dermis. And here as well, mild perivascular infiltrate. You can make out a few eosinophils here and there actually. And that was a clue. When I first had, so the patient had 2 biopsies, but I only saw the first one initially. And I saw a few eosinophils. You can see lots of them here. Eosinophil, eosinophil, eosinophil. You see lots of them here. A perivascular lymphocytic infiltrate, no vasculitis, mind you. And you see an intraepidermal, lots of eosinophils here as well, if you look at the slide, and an intraepidermal pustule, subcorneal actually, with lots of neutrophils, okay, and a few eosinophils scattered here and there. Now, this was a puzzle for me because I didn't have the second biopsy at that stage, and I was thinking, it's not pleva. The infiltrate is superficial and deep, and I've not seen this deep an infiltrate in just papillary urticaria. There's a bit of infiltrate on the eccrine glands. Can you see that? And I was a bit puzzled. I wasn't sure what was going on. I thought maybe an id reaction with secondary, pustule formation here. I wasn't quite sure. So this brings us to the second biopsy, which is actually the clue. But again, on low power, this foxed me. And this second biopsy, in fact, I've only shown you the third level of this. The first level did not have the clue. And I'll tell you what the clue is in a second. But you can see a superficial and deep infiltrate again, going quite deep. I mean, I've never seen this deep an infiltrate in this particular entity. Okay. Now you can see that the infiltrate is superficial and deep, going around the vasculature. A hint of even, I don't know why it's not zooming properly. Maybe it's just a buffering thing here. Sorry about that. But you can see that the infiltrate is superficial and deep. Lots of nuclear dust here. And the clue here is this particular, actually, the subcorneal thing. There's a space in the subcorneum, And when I did the first levels, I only saw the space. I didn't see anything inside it. And I was puzzled. I wasn't sure what was going on. And because of the sections were a bit torn apart and the technician did a shoddy job, I asked for deeper levels. And that's how I got this. And look at this beauty here. This is the scabies mite. And I don't think you can get it wrong. If you've seen it once, you've seen it and you won't miss a diagnosis. This is a typical example of, the why scabies is called the 7-year itch. And even histopathologically, if you're only seeing the first section, or even if you'd seen, first biopsy, or if you'd seen the first section in this particular case, you wouldn't be able to make the diagnosis because lots of nuclear dust, there's a lot of perivascular infiltrate, quite superficial and deep, quite dense infiltrate, and lots of nuclear dust. I personally wasn't sure what was going on until I homed in on this friend here. So this is scabies, and quite a few of you have got it right, actually. Let us look at the diagnosis. 34 of you have got it right. We decided not to give any marks to any of the differentials because this is scabies. I think some of you chose PLC because that was what in the differential, but this is scabies. So let us look at the chat box here. I think there are no other questions. So happy to take any questions, guys, and we'll be announcing the result in a second. I'll just switch on the screen sharing for a second and let maybe Dr. Manoj Singh sir talk about how the session went and share his thoughts on how the future sessions will go. Manoj Singh sir, on to you.
Now I should be audible. I hope you all enjoyed our effort at whatever we are trying to do. And one baseline criterion I'd like to put in right here. The reason why we have set up this entire organization is to disseminate and try and publicize and try and popularize our specialty or our subspecialty. I will be the first to acknowledge that three of us are great pundits of dermatopathology. The reason I'm saying that is very clear. We, especially Nand and I, are great pundits because we have been, digging away at this for 30, 40 years or something. And Sasi is actually a little junior to us, but then he is a great pundit because of his, qualifications, his work in the UK and so on and so forth. So our issue is that we all started at the same level. There was a time when I was doing my MD and a little after that, when actually dermatopathology for pathology residents was a scary subject because of that book, a huge book. Liver was something which a lot of people used to read. And then the other thing, of course, was the fact that the skin is right here. The skin is, where am I? Here. Skin is here. Skin is not, inside the abdominal cavity or inside the cranial cavity or something. So whatever is happening in the skin is immediately seen. And it is for this reason that, dermatology or dermatology for internal medicine people has become such a widely talked about and discussed issue because, anything happens in the skin, 20 people may see it. And as a result, there is a huge confusion of nomenclature. There are different names for the same condition in Germany, in German, in French, in the USA, in the UK, in India. Because everybody sees the same condition, they describe it differently. So there are a lot of eponyms that so-and-so's condition, so-and-so's condition, so-and-so's dermatosis. And it's the same condition we are talking about, which is actually another very important niche for the pathologist, because the pathology of, whatever the clinicians might be naming it, the pathology is common, follows one track. And that is the reason why we actually, almost 25, 30 years ago, we set up the Dermatopath Society of India, because of our conviction that any skin lesion for diagnosis has to have the clinical component and has to have the pathology appearance. So dermatopathology is something which we have been talking about as a compound entity. And over the years, we feel that we have been, proved correct in a large number of cases. In other words, we have, say, something very characteristic like lichen planus. Now we have a lichen planus, and then we have the lichenoid group of disorders. Now, lichen planus itself has been clinically diagnosed as, so many things, so many names. But lichenoid group of disorders means that there is a lichen planus-like change caused by something else. Of course, lichen planus, what causes it, again, we are not sure. We don't know exactly what causes lichen planus, but the lichenoid group of disorders. So if you see a case of lichen planus and it's given to you as no history, and you call it a lichenoid disorder, lichenoid whatever, you are correct. That, it may be something which is looking like lichen planus, but not lichen planus. So these are the niceties of finenesses which we go into as we progress. And as I said, we are sort of there because we have been, doing this kind of exercise. And this is why we have, put this group together to invite more and more of you to join us. Join us in the study of the skin, the clinico-pathological study of the skin, and let's see where we land up. So, as we had briefly told you in the beginning, that we will be doing many combos. We'll be doing academics. We'll be doing CPCs like this. We'll be doing we'll have a library. We'll have this. We'll have that. We may even end up having a certificate course. So we are going to see what we end up doing. So, with your cooperation and your blessings, we hope that we, end up with something substantial. Sasi, Nand.
Okay. Thank you, sir. So on that note, I just want to mention 2 points, just add on 2 points, sir. One is the fellowship that you mentioned. We are actively going to try to, affiliate with the university and get this fellowship, affiliated and recognized by, the NCI, and hopefully, this should happen soon. And that would give a bit more credence to our fellowship. The second thing is the diagnostic aspect. If you want to send in slides to DADI, we are still working on the technical aspect of things. So in the next month or two, we'll be opening up. All of us are reporting in our own capacities, but for DADI to be reporting to start our diagnostic services may take another month or two, and we'll keep you updated. On that note, I'm pleased to announce the winners. In fact, there are 4 winners who've scored equal marks. Now, we did think that we were going to give the first prize winner a prize, 5,000 rupees worth of DADI modules, and the remaining people were going to get books. But then, because we have 4 winners, we decided to give them each 1,500 off on our modules whenever they want to subscribe. And hopefully, Glodama is sponsoring the IADVL Dermatopathology book. And hopefully we'll get 1 copy to each of these winners. So we have Priyansh Gupta, Nelri Gonsalves, Hitashi Sethi, and Anusara Philip. Congratulations on scoring 800 out of potential 900 marks. So well done for scoring as many. And the rest of you, as you can see, this is a very anonymous type of quiz. So only the winners are being declared. You can put in your answers, and we are not going to show your names or anything. So don't feel shy. If you want to take part and your friends want to take part in future quizzes, you can see how it's going. And you'll be actually, once the quiz is over, you'll be emailed a percentile score. And a percentile score tells you how you've done compared to your peers. So out of 77 people, if you've scored maybe 600, and that's the 75th percentile, you'll be able to know that, and you'll be able to rank yourself out of the people who've taken this particular quiz. So yeah, I think that's all I have to say. And thank you very much. Dr. Nandakumar is missing in this group. Dr. Nandakumar, are you still there?
Yeah, I think all that has been that needs to be said has been done. I wish all our participants have enjoyed this particular session, and many more sessions are in the offing. Learn dermatopathology, enjoy learning dermatopathology, and I want more and more people to take up dermatopathology as a subspecialty, both in the field of, those in the field of pathology as well as in the field of dermatology. Yeah, that is all from me. Sasi.
Thank you very much. I think we can end the session unless you have anything else to say, sir. Manoj Singh, sir. Excellent. So, Rohit, I think we can end the session. Thank you very much.
Yes, sir. Yes, sir. Thank you so much, sir. Thank you. Thank you, all of you. Technical team, just end the meeting.